Hello and welcome to the Respiratory System Pathology recorded lectures. Let's get started. Before we begin looking at pathology, I want you to recognize some common signs and symptoms of respiratory illness. Now, these are signs and symptoms that may be on the requisition or the order from the physician, or these are signs and symptoms that the patient may report to you or that you may notice. So dyspnea, remember that means difficulty breathing, so labored or forced breathing. Pain. Now, when you are describing chest pain, it is not enough to say the patient has chest pain. You have to be very specific. Right, left, medial, anterior, posterior. Be as specific as you can for the radiologist. Cough. Cough is a very normal sign and symptom of respiratory illness. We're going to take it a step further and ask our patients if that cough is productive or non-productive. And in layman's terms, what that means is, are you coughing anything up? That would be productive. Non-productive means they're not expelling or coughing anything up with their cough. Okay? Fever. Malaise, remember that refers to this vague feeling of illness, weakness, I just don't feel right, something's off. That's malaise. Headaches, and then cyanosis. And remember, that refers to a blueness of the skin, and it's generally caused by a lack of oxygen. So hopefully you only see that in kind of acute emergency or inpatient situations. You don't run across cyanosis as an outpatient very often. There are several categories of respiratory disease that we'll discuss in these lectures. First of all, respiratory diseases of the mediastinum, pneumoconiosis, and that refers to respiratory diseases that are attributed to occupational exposure. And we'll talk more about that later. Inflammatory respiratory diseases, the COPD family of respiratory diseases, we'll discuss a few of those. There is a genetic respiratory disease we'll discuss. Neoplasms. Now remember, neoplasm is a term that refers to new growth. Neoplasms can be benign or malignant. So a neoplasm is not necessarily a cancer or a malignancy. And we'll talk more about that later. And then there's a whole category of miscellaneous respiratory diseases that we'll discuss. Couple other things to note before we get started. Remember, rales refers to a crackling sound in the patient's lungs. So the nurse may report to you, or you may see it on their requisition, that they're experiencing rales. That's just an abnormal crackling sound when they breathe. Hypoxemia, that is an oxygen deficiency. So again, that may be something that you see on the requisition and something that you can report to the radiologist. Many facilities want you to ask the patients if they've had a history of smoking, because we know that so many respiratory diseases arise from a history of smoking. So, are you a smoker? Have you ever been a smoker? When, how long have you smoked? Those are kind of important questions for the radiologist. Any previous surgeries, that's going to be very important, because what if they've had a lobe of their lung removed? That's really important information to share with the radiologist. And why? Any trauma, such as broken ribs, sternum trauma, again, those are all things that we want to note for the radiologist, and when that trauma occurred. Was it a week ago or was it 10 years ago? Because that can impact our respiratory system. And then high blood pressure, that is also something that may be helpful, particularly if we're looking at the heart. Okay, there are a couple new terms that I want you to be familiar with. A radiodensity, so that is something denser than the surrounding tissue. And on an x-ray, it's going to appear white. Well, guess what? If you have a tumor in your lung, usually that appears as a radiodensity. So it is white and it is denser than the tissue around it. So it absorbs or attenuates more of our x-ray beam. Radio-opaque, that refers to something that shows up on an x-ray. And again, it's a radiodensity would be radio-opaque. Radio-opaque objects absorb or attenuate our X-ray beam and appear white. Okay? The hilar region, remember that refers to the hilum of the lungs, the central area of the lungs where our blood vessels, our bronchi, our lymph vessels come and go. A nodule, that is a small rounded lump of cells in the body. And lung nodules are concerning because what if that's an early tumor just, developing and growing? But nodules can be benign as well. So it's important that we don't jump to any conclusions about the malignancy of a nodule because they can be benign. Calcifications. Calcifications can occur anywhere in the body. They are small deposits of calcium. You can see calcifications in the lungs, in the breast tissue, and again throughout your body. So you'll hear that term a lot. Number 6, pneumoconiosis. Remember, that is a lung disease that is caused by occupational exposure. And more to come on that. Last one, an infiltrate. So a pulmonary infiltrate is a substance that is denser than the air in our lungs. So again, it'd be a radiodensity. It would also be radio-opaque. It could be something such as blood or pus, and it lingers within the parenchyma of the lungs. So, that's causing perhaps a shortness of breath. Maybe they're expelling some of that when they cough. So examples of infiltrates, you may see an infiltrate if the patient has pneumonia or tuberculosis. So it's this substance within the parenchyma of the lungs. And it's abnormal. It's typically concerning, like, why, that shouldn't be there. These are all terms that you will hear as we describe our pathology. So I wanted to introduce them to you now. All right. Let's begin our discussion with disorders of the mediastinum. And there are 3 that I want you to be familiar with: pectus excavatum, pneumomediastinum, and lymphadenopathy. Now, before I begin, let me just say, when we are discussing pathology, technologists are expected to have a general knowledge of pathology, no matter what the body system is that we're talking about. So our job here in the radiography program is to introduce these pathologies to you, and then you will see them at clinicals and kind of get more familiar with them. I don't expect you to be an expert in pathology. That is the radiologist's job. But you are expected to have kind of an introductory working knowledge of some of these pathologies. So my goal for you is that you can correlate the name of the pathology with its definition. I've included pictures because it's interesting and fun to look at for us. But what I want you to focus on right now is connecting the name of the pathology with its definition. Identifying pathologies on an X-ray will become easier as you go. Let's get started. So, pectus excavatum. This is also known as sunken or funnel chest, and it is a congenital chest wall deformity. And what that means, congenital means the patient was born with it. And what happens in pectus excavatum is that the ribs and the sternum actually grow abnormally, and it produces this concave or caved in appearance in the anterior chest wall. This image actually depicts a 16-year-old boy that's got pectus excavatum. Now, this is just informational, you don't have to write this down. Pectus excavatum is the most common type of congenital chest wall abnormality, accounting for 90% of chest wall abnormalities. It occurs in approximately 1 in every 300 to 400 births, and it is more common in males than females with a ratio of 3 to 1. Surgery is going to be the most common treatment for this condition. So please know that pectus excavatum is a sunken chest, and it is a congenital deformity where the ribs and sternums actually grow abnormally. Next, pneumomediastinum. So pneumomediastinum is the abnormal presence of air or gas in the mediastinum. So whenever you see the word pneumo, that's going to refer to air or gas, and then mediastinum, so air or gas in the mediastinum. Okay? This condition can result typically from physical trauma. The main symptom is usually severe medial chest pain. Other symptoms may include labored breathing and even voice distortion, as though the patient has ingested helium. Again, here's an example of a pneumomediastinum. You can see the mediastinum is widened, kind of has this abnormal wall right here. And again, all I want you to be able to do right now is connect the term pneumomediastinum with the definition, abnormal presence of air or gas in the mediastinum. Okay, last of the mediastinal disorders, lymphadenopathy. So lymphadenopathy is a bilateral, meaning it occurs on both sides, okay, bilateral enlargement of the lymph nodes. And here we're talking about lymph nodes that occur in the hilum of the chest. So remember, the hilum is that central region where lymph vessels come and go, our bronchi come and go, our blood vessels, etc. So when we're talking about lymphadenopathy in terms of respiratory disease, it's that enlargement of the lymph nodes is occurring in the hilum region of the chest. Okay. The most common way to identify lymphadenopathy is on a chest x-ray. Now again, you can have lymphadenopathy anywhere in the body. We are referring to in the hilar region of the chest. So if you are trying to look for lymphadenopathy in the chest, a chest x-ray will show that nicely, particularly if they're very enlarged, which you can see here. So you don't have to write this down. This is just a fun fact. This patient has sarcoidosis, and that is a systemic inflammatory disease that can affect any organ. However, 90% of those affected with sarcoidosis have lymphadenopathy in the chest. We don't know the cause of sarcoidosis. Some believe it's due to an immune reaction to some sort of trigger, like an infection or chemicals in those who are perhaps genetically predisposed to have immune reactions. So please just know that lymphadenopathy is an enlargement of the lymph nodes, can occur anywhere in the body, but this unit we're discussing respiratory, so it would occur in the hilar region of the chest. Okay, we are going to pause here. We'll pick up with the next set of pathologies in part 2.